Okay, today we'll be talking about abdominal ultrasound study, mainly the liver and spleen. All right, so the significance of the ultrasound study, how we use this technique, and also tips to make a good images, which is very important uh, to diagnose something abnormal in the liver and spleen. And then the lastly, I will emphasize some of the points when I make a diagnosis of the hepatic and splenic lesions. So why do we do the ultrasounds? It cannot replace the radiography or the radiographs. This is a very important idea. However, nowadays I think people want to do ultrasounds first, especially when you have a patient with the GI signs or gastrointestinal signs. And I don't think it's a good idea. I think you should still do the radiograph first. And then if you don't see anything much, especially in the case of the liver and spleen, you might want to do the ultrasound. So I would definitely take both. Even I might include the 3-view thorax to make sure we don't have anything else going on, especially in the old animals. Ultrasound image can be good to describe the internal changes, which radiograph cannot really tell. Also, we can evaluate the echogenecity and then narrow down the possible diseases. Also, sometimes we can do the functional evaluation. That is mainly the GI tract, not the liver and spleen. But cannot make a definitive diagnosis. This is a very important part. Some of the people think ultrasounds can tell you exactly what's going on. Even the case of the, let's say, gallbladder disease, yeah, sometimes you may be able to say that's a mucocele, but other time you just make sure to make differential diagnosis, and that's the important part of the any imaging modalities. Then why do we do the ultrasound? So we can see the tomographic images. So let's say that's a good thing because CT is expensive. We can see the those cross-sectional images of the liver and spleen. So it's a pretty much a good idea to do, especially we don't have to use the anesthesia. So we can do the fine needle aspirate and maybe getting the definitive diagnosis. We can say if it's a solid abnormality or the cystic structures, we can pretty much say the character of the or characteristic of the lesions. I always use these slides. Most of the time, we are not doing good job to making tentative diagnosis and offer that to the owners or clients. Sometimes we can say young animals, these kind of a disease may happen more often than the older one, or vice versa. History, not many people are taking many histories or complete histories. Especially from the history, we should be able to pinpoint somehow the physical exam. Of course, we do the complete physical exam head to toe, but I think you can emphasize some of the part, especially checking the size of the liver, size of the spleen. Those are the very important things you should be able to do. And then you make a tentative diagnosis. Because of that tentative diagnosis, we can do the differential diagnosis list and then offer the next examinations while we are explaining about the cost. And then the owner can decide what to do. This is the true consent, I think, owner consent. Everybody talks about that, but not many times are we really offering to let them think what they want to do. Rather, I think you might be saying, well, we will do. That's probably a different approach I will make. So radiography, ultrasounds, CT, MRI maybe a little bit different. CBC, blood cam, urinalysis. These radiography, ultrasounds, CBC, blood cam, and urinalysis. They are my minimum database. And then based on that, I might just go to do other tests, like a metabolic disease check, such as what you call those low dexamethasone tests or something like that. Or we might do the CT. And in the abdomen, I don't do much of MRI, but in certain cases, MRI may be helpful too. So once I find some lesion, the key is to get the FNA or biopsy, so cytology or biopsy or histology to get the definitive diagnosis. Once we get the definitive diagnosis, it is easy to just check the textbooks in the United States. Usually they talk about prognosis, treatment methods, and in your hospital, you can clearly say what kind of a cause the client is facing so they can make a decision what to do next. In the case of the liver disease, it is difficult to make definitive diagnosis because their clinical signs are very non-specific. So most of the time you need to have a biopsy. So if we can do the laparoscopy, that would be great because surgery is pretty much invasive. Laparoscopy only 2 or 3 holes and you can get the good biopsy samples. The problem is here. Clinical signs are not specific. So like sleeping all the time, but that means usually an old dog usually sleeps a lot. GI signs, vomiting, diarrhea, you tend to seek the GI problems, but it could be due to the liver disease. Icterus may be a little bit easier because more direct association with the liver. But if it's a hepatic icterus, then of course the liver doesn't really do anything about the condition, I think. So more of a hemorrhagic or I think the hemolysis events, that's the major thing. And this is the biggest headache to me because, okay, alkaline phosphatase, ALP is high, or other, like ALT is very high. That can be associated with the bad teeth. So these are the kind of a problem we see with the liver disease. So that's why we sometimes call it as a silent killer disease, I think. Ultrasounds, hair clipping, of course. You don't do that. I teach to clip the hair. Why not? Yeah, you can do the study without clipping, but that will not give you the good quality of images. I think the good quality is your job to make sure you have that. Okay, and my approach is next to the xyphoid. I don't do much of the intercostal approach. Pivot fanning, the 1 point, and then the kind of a tilt. I usually use that in longitudinal and then transverse. I change how to hold so that like longitudinal I'm holding this way, but the other transverse I'm holding this way. My palm is always in the same direction. And then on the transverse pivot, same. 1 point, right side, middle, and left side. That's how I completely see all the liver areas, except maybe the caudate liver lobe. Okay, and then the depth is usually 4 to 6 centimeter in Japan because we are mainly dealing with small breeds of dogs and cats. However, in the United States, you may be dealing with middle to large breed of dogs, and then you may need to use like 8 to 10 centimeter. If that's the case, you may need to use like a 5 megahertz transducer or the frequency. No, normally or usually I use 10 to 13 megahertz frequency. Microhepatia is very difficult to see because of the small size of the liver. So sometimes from the next to the xyphoid approach, you may not be able to see. So in that case, intercostal approach may be needed. However, clipping is a problem. So if you can push the transducer deep into it, most of the time you should be able to see the entire liver. However, in the big dogs, CT examination may be another option because you can use multi-phase intravenous contrast studies. So the approach to the river, I made this video. So I show you that. So I'm just pivoting. And then seeing the left side, now I'm going to the right side, and then I see the gallbladder. I saw briefly the mirror images artifact. I'm looking at the mid part so that you can see the esophagus and the aorta, and now the mainly the fundic part. On the transverse view, so that my palm is the same, but I'm holding 90 degree. So the counterwise rotation. So I do the same, the right side, then I can check the gallbladder again, the location, midline location, and left side. This is the time I compare the portal vein and then the hepatic veins. That's about the same, or maybe the hepatic vein maybe just about 1.5 times up to. So if I see the twice more, twice bigger hepatic veins, then I worry about the congestion.